Assalamu alaikum. On behalf of Ahsan Academy, let me welcome you to a presentation on the artery supply of lower limb. This is the first part of a series presentation on the subject I have mentioned. This presentation has the following objectives. I'll try to cover the general aspects of lower limb circulation. Then every arteries will discuss the origin, course, branching, and termination, and at every stage we'll try to correlate clinically. Circulation of the lower limb, as usual, starts from the heart, and it's a systemic circulation. That means that larger blood vessel arises from heart, then these blood vessels, artery, passes through a bed of capillary in the periphery and unites together to form the vein which drains into the heart again. So this is having one set of capillary in the circuit. So it is systemic circulation. Here you can see two nice students sitting in front of us. How do we identify them? By the name. Suppose this one is having the name Nasima, another is Nasim. Many times we get students in the same classroom with the same name. So in that case, how do I confirm the identity? Then definitely we'll look back, means we'll search for the parent's name. So remembering the name with the parent's name will help you to identify correctly. So this is true for the name of the artery. We try to identify the parent source, like it is directly arising from heart, or it is the branch of some artery, like this is the brachiocephalic trunk, which is the branch of arch of the aorta. And similarly, on the left side, common carotid and subclavian are left subclavian are the branches of arch of the aorta. So with the name of the parent's artery, we usually match the name of the artery. So this, we have found that the arch of the aorta actually continues in the thorax as descending thoracic aorta. This is visible in the figure. This is passing through the posterior mediastinum, crossing the descending thoracic aorta, passes through the opening in the diaphragm at the level of the 12th thoracic vertebral body. This is known as aortic opening and become the abdominal aorta. This is the level of the aortic opening. Then it passes in front of the lumbar vertebral bodies up to the lumbar 4 level. Here it divides into two branches, that is the right and left common iliac. You can see this is the left common iliac, and this is again divided into internal iliac and external iliac. External iliac is directly going to the lower limb, but internal iliac, mainly supplying the pelvic structure, gives some branches to the upper part of the. And so this is the abdominal aorta divides into common iliac. So the main sources of the lower limb is the external iliac artery. This is the external iliac artery continuing as the femoral artery and subsequently gives branches and continue as other arteries. This internal iliac artery gives three branches to the upper part of the lower limb. So general aspects we should consider for each artery is the origin, course, termination, and branching. Through the branching, it actually supplies the structures. So anatomically, this aspect should be known clearly. So in this presentation, I'll cover the femoral artery and the popliteal artery portion and the three branches of the internal iliac artery. Most important clinical aspects here we will discuss. This you can see, this is the right common iliac divided into external iliac, and this one is the internal iliac artery. This happens in front of the sacroiliac joint at the level of the, this is the level of intervertebral disc between the sacrum and the fifth lumbar vertebra. So at this level, in front of the sacroiliac joint, it divides into this internal iliac and external iliac. This internal iliac gives some branches to, these are the three in number: superior gluteal artery, inferior gluteal artery, and the last one is the obturator artery. So these two are going to the gluteal region, and this is going to the medial side of the thigh to supply the upper part of the lower limb. The most supply of the lower limb coming from the external iliac, who actually continue as the femoral artery on entry into the lower limb. This is supplying the most part of the thigh and totally supply the part below the knee joint. This is the internal iliac that is giving three branches. Already we have discussed that those are superior, inferior gluteal arteries and the obturator artery. The superior and inferior gluteal arteries going to the gluteal region. Here you can see in the figure, this is the superior gluteal artery, and this one is the inferior gluteal artery passing uh, either side of the piriformis muscle. This is the inguinal ligament. Already in the previous presentation I have discussed that certain structures, those are important, passes undercover, and this gateway allows the structure to enter into the anterior part of the thigh. So these are the structures present here. Is the muscles are, this is iliacus, this one is the psoas major, and the lower one is the popliteus muscle. So these three making the floor of this gateway, and over that this one is the femoral artery, descends into the anterior part of the thigh. By the side means lateral to the femoral vein. This is femoral nerve itself lies lateral to the artery, so it is passing between femoral nerve and femoral vein. This lateral cutaneous nerve of the thigh that also runs under the cover of this ligament. And this is the anterior superior iliac spine. This one is the pubic tubercle. This is the inguinal ligament. So this is inguinal ligament is there, and this is the symphysis pubis. The point is the anterior superior iliac spine, and the upper part of the symphysis pubis. If we draw a line, this is indicating the inguinal line. This is this ligaments lies a bit below and a bit curved below this line. So the midpoint of this line is the mid inguinal point. Just below this, behind the inguinal ligament, the external iliac artery ends and the uh, femoral artery starts. So this is the point from where femoral artery descends. So we can explain by language that it is the continuation of the external iliac artery behind the inguinal ligament. The point is midway between the anterior superior iliac spine and pubic symphysis. This is also known as mid inguinal point. The origin point is just below this mid inguinal point behind the inguinal ligament. So femoral artery, it arises as the continuation of the external iliac artery behind the inguinal ligament and enters into the front of the thigh. So this way we can explain the origin of the femoral artery. It is the mid inguinal point, and just below the mid inguinal point behind the inguinal ligament, the femoral artery starts. This is also known as mid inguinal point, and it is not at the mid inguinal point, it is just below the mid inguinal point behind the inguinal ligament. We used to say the junction. see the inguinal ligament is reflected, and you can see the origin of the femoral artery. Femoral artery, here you can see the femoral triangle. Again, let me show. This is inguinal ligament, and femoral artery arises just at this point, descend below in a triangular, muscular triangular area. This is femoral triangle. So shaded area is femoral triangle. So it is the femoral artery is in the floor, on the floor of the femoral triangle, lying between vein on the medial side, nerve on the lateral side. It descends. Nerve immediately divides into its branches, but femoral artery continues up to the apex of the femoral triangle. Then it hides under cover of this muscle. This muscle is sartorius. So it passes behind the sartorius muscle and enters into the adductor canal. This is the adductor canal. Sartorius is cut off. So it enters into a fascial canal, musculofascial canal. This is adductor canal. This one, also known as subsartorial canal, also known as Hunter's canal. So femoral artery remains within the canal, and the end of the canal is it ends at an opening in the adductor magnus muscle that we'll see. So the arises from the inguinal ligament, passes over the floor of the femoral triangle, enters into the adductor canal or subsartorial canal behind the sartorius muscle, and finally it ends at the level of an opening in the adductor magnus. This is at the lower or distal end of the adductor canal. You can see this is the adductor canal. This is the sartorius covering it. Sartorius is taken off, and so we can say that first one half of the femoral artery lies in the femoral on the floor of the femoral triangle, in the femoral triangle. Then it enters into the adductor canal, and it passes throughout the length of the adductor canal and enters into the opening, into an opening in the adductor magnus, and ends here by continuing as popliteal artery. So most important thing is the artery lies in the anteromedial part of the thigh, in upper third of the thigh, then enters into the subsartorial canal and enters into the middle part, mid third of the thigh, passes through that canal up to the opening in the adductor magnus. This is at the junction of the mid third and the lower third of the thigh. Then it becomes popliteal artery, passing in the popliteal fossa. It is on the back of the knee region, genual region. So the femoral artery remains in the upper two-thirds of the thigh and becoming popliteal artery at the lower part, at the junction between the middle and lower part of third of the thigh. So in entry point is inguinal ligament, exit point is the opening in the adductor magnus. Of this femoral artery is more superficial in the when it lies in the femoral triangle. This one is popliteal artery on the back. As you can see, this is the opening in the adductor magnus. It's going back. It is posterior part of the thigh, you can see, and anteriorly this disappears from here. This is the entering into the opening in the magnus, and you can see the cut part of the femoral artery. Arrow is showing the opening adductor magnus. In the significant part is this is lying on the anteriorly in the upper third, and it is more exposed to the closer to the surface. Then it is going to the medial part of the thigh, and this is more deep in position, but still it is under cover of the thigh, sartorius, and easily approachable by the knife. So this can be cut by stabbing injury, Stabbing injury at the femoral triangle will cut it. Stabbing injury on the medial side of the thigh in the mid thigh will cut the femoral artery and can kill the person because of the rapid bleeding. The branches of the femoral artery will start from the proximal part. Some superficial branches are there. Most important is the superficial circumflex, superficial epigastric, and superficial external pudendal. These three branches of this, the middle one already we have discussed with the hernia, its clinical significance. And we'll get the deeper artery. Closer to them is the deep external pudendal going to the perineum. And the most important branch of this artery is the profunda femoris. Beside this, it is giving muscular branches and branch to the joints, hip joint and knee joint. So we can say the three important superficial branches are this one: superficial circumflex, superficial epigastric, superficial external pudendal. Corresponding deep artery also arises from here, right? Deep external pudendal artery. And most important artery is the profunda. We'll discuss with profunda a bit more, and also having some muscular artery and artery to the joints. You can see the branching pattern. This is the internal iliac, and this is the femoral artery origin behind the inguinal ligament. You can see and giving branches. So just profunda femoris artery is the largest branch of the femoral artery. About 1.5 inch below it arises and passes downward. It is the main supply to the thigh, and muscles of the thighs are supplied by this. This also includes the supply of the two joints at the end of the thigh, knee joint and hip joint. It's important is this is having tremendous anastomosis, some artery going up, taking part, anastomosis in the upper part with the branches of the internal iliac, sending branch below and making anastomosis around the knee joint. So it's have a wide linking between the hip region and also the knee region. So this can be a collateral circulation part. You see, this is the profunda femoris artery having anastomosis above and sending some branches to the knee joint. You can see the branch to the knee joint. So it is having anastomosis with internal branches of the internal iliac and external iliac branches of the femoral artery. So below it goes up to the popliteal artery. So it can be a collateral circulation routes between external iliac and popliteal or femoral artery. So it is the major collateral route. Other collateral routes are also there. And this important thing, another is its supply to the major supply to the head of the femur. We will two clinical aspects will be discussed subsequently. One is the collateral route, another is the head supply of the head of the femur. So you can see this is the aorta, common iliac. This is branch going deeper. So internal and external iliac arteries are there. There is blockade of the external iliac artery. So there is no shadow here. You can see the shadow here, continuation as a femoral artery, but here there is no shadow, means this part is blocked. But still the femoral artery, profunda femoris, is getting blood because of the anastomosis. So anastomosis connecting here the external iliac with the femoral and profunda femoris. So only this part is blocked and other part is still patent. The circulation is intact. The angiogram is showing like this. Now this is the external iliac becoming femoral. So femoral artery giving a branch, the profunda femoris. The profunda femoris is supplying the head of the femur by two sources. You can see this is the lateral circumflex. This is lateral side at pubic tubercle. So this is medial side. So this one is the medial circumflex. It is hooking round, going here and making a circular anastomosis around the neck. Look at this. This is the capsule. So the capsule of the hip joint extends inferiorly up to the intertrochanteric lying anteriorly, but it doesn't attach to the intertrochanteric crest. There's one finger of the neck is exposed and it is attached here. So from the attachment, some connective tissue fibers run with the periosteum up to the margin of the head, and this makes the periosteum here thicker. So this is known as retinaculum. Any deep tissue sheet, connective tissue is known as retinaculum, and this retinaculum covers this intracapsular part of the neck. So this from this anastomotic network formed by the circumflex and their branches, arteries are arising straight, number of arteries, and these are the retinacular artery passes very close to the neck bone under cover of the retinaculum, and they enters into these give branches to neck and enter into the head through some openings here, so supplying the neck as well as head. So this is very closely related to, all the arteries are very closely related to neck bone. You can see this is the retinacular artery. It's passing through this. So any fracture involving the neck intracapsular part will tear all this artery. But if it is extracapsular, this retinacular artery will remain intact. So if the fracture is intracapsular, that will affect the supply of head. Mostly, I'm telling mostly because a small artery from the obturator artery coming through this ligamentum teres femoris to supply a small part close to this fovea. So this part will remain intact, rest of the part will die, including the neck that is fractured from the main femur. So this is a clinical significance of the artery supply of the head. You can see this X-ray is showing different parts of the upper part of the femur and the hip joint. This is the head of the femur, this is the fovea, and this one is the acetabulum. So joint is intact, the total bone is okay. You can diagrammally show this is the position of the arterial circuit, arterial ring, and from there these are the retinacular artery passing to the head, and it is intimately related to the intracapsular part of the neck as it is covered by the retinaculum. Now we'll go for the next slide. If fracture occurs here, what will happen? And if fracture occurs here, what will happen? These two figures. This is intracapsular part of the neck is fractured. You see, this is the outer part of the neck is intact, but this part is showing distortion of the bones, and gradually the total bone will die in time. Look at this. Fracture line is from the trochanter to trochanter. So extracapsular fracture is there. So you can see the neck is very good, shadow is clear, the joint is clear, head is clear. So extracapsular fracture, the neck and head will be okay. But intracapsular fracture, the head will die. Only a small part close to the fovea will be spared because that part is supplied by the branch of obturator artery, and that is passing to the head of the femur through ligamentum teres femoris, or that ligament is also known as ligament of the head of the femur. So that part only remains intact. You can see this is the ligament and a small section of the artery is visible here. This part is known as fovea. So intracapsular fracture of the neck leads to necrosis of the femur head. Let us go in detail of the popliteal artery. We came to know that this is the opening in the adductor magnus. So this is the place where the femoral artery continues as popliteal artery. So on passing through this, it becomes popliteal artery and enters into a diamond shaped area. This is popliteal fossa. So this is the site of origin of popliteal artery. You can say this is the popliteal artery arises as the continuation of the femoral artery at the opening of the adductor magnus. After arising here, after origin from there, it enters into the popliteal fossa and descends in the popliteal fossa. You can see the artery here, all muscles are removed, so it is passing here down between these two bony components, and this is known as the lateral, and this one is the medial femoral condyle of the lower end of the femur. So this in between this area is intercondylar fossa or intercondylar area. So it passes through this area, so it is very intimately related to the bone here in this position, and then it goes down, and this muscle is popliteus muscle. You can see the everything is removed. This is the popliteus muscle, and this is the lower border of the popliteus muscle, and here this is popliteal artery going down, and here it divides into two close to the lower border of the popliteus. So course is very easy. It enters into the popliteal fossa through this opening to become popliteal artery, passes in the floor of the popliteal fossa, runs between the two condyles of the lower end of the femur in the intercondylar fossa, crosses the knee joint, and passes over the popliteal muscle to be to at the lower part of the lower margin of the popliteus, and then it divides into its terminal branches, anterior and posterior tibial arteries. So from the opening of the adductor magnus muscle to the lower border of the popliteus is the termination place, and here this is the neck of the fibula. So bony mark, we can identify that it divides at the level of the neck of the fibula, which is close to the lower border of the popliteus muscle. Here you can see the total course, and let us go for the termination. This one muscle gastrocnea, and this is soleus. So it hides under the soleus muscle to divide into anterior and posterior tibial artery. You can see this is the gastrocnemius and soleus. Under that, it is divided into its terminal branches. This one is the sciatic nerve. All through course, it is very close to the sciatic nerve. Then sciatic nerve divides into common peroneal and tibial nerve. So it continues with the tibial nerve, and throughout the length, it is parallelly related to the popliteal vein. This one is the popliteal vein, and terminate at the level of the close to the lower border of the popliteus, at the level of the neck of the fibula, under cover of gastrocnemius and soleus. What are the branches? Let us see. This is the popliteal artery, giving branch on either side, superiorly and inferiorly, going to the joint, and this one is the middle one that is directly going into joint, and it is single in number. So it is having this is popliteus muscle, lower border, close to it, near the neck of the fibula. It divides into anterior and posterior tibial artery. This is anterior tibial, and this one is the posterior tibial. So this is the termination point. So it has 5 branches to the joint, and this one is the middle, and above there are 2 lateral superior and inferior lateral genicular branch. Similarly, this is superior and inferior medial genicular branch. So 5 genicular branches are there, and more than one sural arteries are there. These sural arteries are supplying the nearby muscles. So muscular arteries arise from this common sural artery. This may be single or multiple. can see how the artery are spreading all around the knee joint. This is the termination point. Let us have a summary. This is the popliteal artery total course. You can see this one is the opening in the adductor magna. So popliteal artery is the continuation of the femoral artery at the level of opening in the adductor magnus. Then it continues in the popliteal fossa, giving some branches. Right under gastrocnemius, goes up to the lower border of the popliteus muscle, and hides under soleus to divide into two terminal branches. So this is having 5 genual branches, sural arteries, and 2 terminal branches. This is the summary of the popliteal artery. Now, anastomosis around the knee joint is very important clinically, that we'll discuss in the next subsequent slide. So how this anastomotic, or between whom this anastomosis takes place. The femoral artery descending genicular branch all through, and they take part in anastomosis. Lateral femoral circumflex artery that sends a genual branch that descends, and popliteal artery gives 5 genicular branches, means branch to the artery joint, knee joint. Profunda femoris giving a long artery that passes from the branches going to the muscles. So profunda femoris artery gives branch to the muscle known as muscular arteries, and from there arises the genicular branches. Anterior tibia is situated below the knee joint, so it is giving recurrent branch to, it is going back to the knee joint. So this is anterior tibial artery giving recurrent artery to the joint. Significant of the anastomosis is you can imagine when remaining straight, easily arterial blood can go down, but when we bend the knee joint and more, there will be kinking of the or narrowing of the popliteal artery because of the pressure. So at knee joints, this is significant that often, because of some spatial position where we remain in the position for a longer time, the blockade, physiological blockade, will be severe. So that will hamper the blood to the lower part of the lower limb through the popliteal artery will be reduced. And you see, this is the place where it is narrowed down, and there may be anatomical blockage. This angiogram is showing very intact artery here, anterotibial, posterior going, dividing, but here you can see above the knee joint, it is in the popliteal fossa, popliteal artery is blocked, but just below the popliteal artery is getting sufficient blood to be and to supply the lower limb, and the size is almost equal, not equal, but almost equal. But subsequently, for a longer time, if it stay, that can be dilated to become equal. So this collateral circulation is possible because of the anastomosis around the knee joint between several arteries. So can maintain easily physiologically, or their clinical blockage is there. The lower limb can be can get the artery supply sufficient to maintain the life. Thank you very much for remaining with this presentation.